Good afternoon, everyone, and welcome to today's webinar hosted by First Illinois Chapter of HFMA. The title of today's webinar is Preventing Leakage with Proactive Revenue Protection Strategies. I'd like to welcome today's guest presenter, Jonathan Wiik. Jonathan currently serves as a principal at TRANSUNIon in the Healthcare Strategy Division. During his 20-year tenure in healthcare, Jonathan has been in various roles across the hospital and payer market, including hospital transporter, manager of operations, senior regulatory analyst, product development, director, and CRO. Jonathan was a member of the American College of Healthcare Executives and actively involved in legislation and industry changes shaping healthcare. Jonathan actively serves on the Colorado HFMA board and is president of the board of directors at an assisted living facility in Boulder, Colorado. Jonathan has spoken at several national and state events and has developed several nationally recognized programs in point-of-service collections, financial clearance, and sharing best practices in hospital operations. So without further delay, I'll hand the call over to today's guest presenter. Jonathan, please go ahead.
Thanks, Nikki, and thanks to all of you out there in the great state of Illinois. I spoke at your chapter in the fall, I believe, and it's always an honor to speak to this group. It's a very savvy and in-touch group with what's happening in healthcare. I got about 30 or 40 slides here to go through, and then we got some Q&A at the end. I certainly can help address things. I want to make sure you guys have some actionable takeaways from today, and so if there's something that you saw that you liked or wonder if there's a tool or a workflow on those things, feel free to reach out. My information's here, and last name's 2 I's and a K. Zip me an email. I'm happy to ship anything I can to you. I want to make sure I'm a resource to you as well. Well, let's dive in and get to it here. Today we're going to learn about 3 things: market drivers and trends impacting revenue leakage. That's a pervasive topic right now in healthcare, specifically as it relates to uncompensated care, a combination of bad debt and charity, coverage disruption. We'll talk a lot about what's happening with Medicaid in the exchange plans, and finally, everyone's favorite, denials. It seems to be a _1 issue right now. Is there's a lot of leakage happening through losing earned revenue that you have, and through a changing insurance rule or failure to follow the standard work that's in place to insulate that revenue. Finally, secondarily, we'll look at these leakage points, what you can control and what you can't, why things are happening, and some strategies and how to kind of plug those leaks. And finally, I'll give you some battle-tested workflows, either at my hospital or from some other hospitals in the country that I've visited, to talk through best practices and kind of applications in protecting your revenue cycle. And as I mentioned, if there's anything you see that you need some elaboration on, that's typically a summary in these presentations. I've got a Rolodex of other things if you need them. Let's talk about some market forces here first. So, I'm a Star Wars fan, so, may the legislative forces be with you. I don't think I've seen, since I've been working here, I'm starting to get old, but the industry have as much legislative banter as we saw last year. We saw the ACHA and the ACA and the BRCA, 5 iterations of this repeal and replace happen, all failed. Of course, repeal and replace was not a household term in 2016, but it certainly was prevalent last year. You're seeing a large prevalence with the CMS waivers, the 1115s and 1155s. Florida just renewed theirs. Indiana, Senator Verma, who's over CMS now, had a very successful waiver program there. Block grants are certainly still being talked about. There are proposed Medicaid cuts still in the legislature that are happening today. The tax reform bill did pass. I've got information. It's not necessarily in this deck specifically, but how that impacts your hospital's finances and revenue cycle from the new tax bill. There's some really interesting rules in there on how your executive payments are capped and how the tax breaks that you were not getting can no longer be received, and there's some benefits as well. 501R, that's a passion of mine. I'm kind of a geek when it comes to that legislation, but that has certainly caused administrative burdens for hospitals for reporting and complying financial charity. I'm in the great state of Pennsylvania today, and they just recently passed a law in December surrounding notification requirements and documentation of those notifications for patients that qualify for charity. And then finally, state transparency. I call the transparency rules the unicorn. Everyone can describe what transparency is and what color it should be and whether it has a rainbow tail and those types of things, but no one's ever seen the unicorn or transparency. So several states, including Colorado, where I come from, have had transparency laws. Ohio, Illinois has some interesting rules that are in the legislature as well. But happy to dive into those. But those forces are all things that you have to comply with, and they keep changing on you. One of my mantras is healthcare has more regulation than nuclear power. Go look it up. It's hard to keep the rules and keep your patients in check. Reimbursement isn't getting any better. There is not incremental reimbursement happening to hospitals. The rates from payers continue to decline, putting financial stress. Hospital bad debt has exceeded or projected to exceed $50 billion by 2025. That's a very, very large number. Leakage, which we'll talk a lot about today, it's an urgent problem. I think the incremental reimbursement that you've negotiated with your contracts or what you may or may not be getting from the government reimbursement is getting chipped away either through things like SGR or through reduction in dish payments or changes in Medicaid enrollment, or just frankly the contracts aren't performing as they were modeled, either through patient bad debt through increasing cost sharing through high deductible plans or denials from improper eligibility or unfollowed up things. So we'll talk through revenue leakage quite a bit today. Pay me now or pay me later. Again, another revenue leakage topic, but getting paid properly from your patients and your payers is paramount for revenue cycle. 1 to 5 of all uncompensated care accounts actually have billed coverage out there that most of the hospitals do not know about. We will talk about that as well, and try to talk through those workflows and solutions to see if they're a fit for you. And then finally, data integrity. Insufficient, inaccurate, disparate, and missing data, either in the hospital or payer databases, is causing consternation for the back end from the front end in terms of information that is outdated and incorrect, resulting in an unpaid claim or an unbillable patient. So those all impact that revenue. But those are some big forces today that are hurdles that we all must navigate. Let's talk about uncompensated care and coverage disruption. I'm a geek. I follow the AHA report that comes out. They just released one right around right before Christmas time. And for the first time in 2013, we're seeing an uptick. Uncompensated care was reported in that December report at $38.3 billion with a B dollars. It was at 35.7 in 2015. It had a slow decline, obviously, from 2013 down from the Medicaid expansion and some of the Obamacare stuff. But we saw an uptick there. We'll certainly talk through some of the drivers of that. I think you're seeing a lot of disruption in the market from folks either eloping from Medicaid because they couldn't feel they could get on it. The health benefit exchange plans have seen a lot of vacancy. I'm seeing folks just not being able to afford. They're increasing in premiums as well on the commercial side. And you're just seeing a lot of patients not being able to afford the care that they're on. They're underinsured or they're frankly uninsured. But we're seeing an uptick in that rate in our country. On that note, this is kind of a fun graph. This comes from my book. But in the book, we talk about the uninsured rate. In the 50s and 40s, there was a very, very high uninsured rate. It was almost no one had insurance, and then it drops down to the 30% range with the Blue Cross and Blue Shields and Baylor plans when those came. And then when we had HFMA, I actually interned at HFMA. That's now known as CMS for those that are newer. But the Healthcare Financing Administration came about. They created Medicare, Medicaid. That got that number in half down to about 15%. We saw SSDI come in 75, brought it to 12. And then, of course, what we're all very familiar with is in 2014 we had the exchange plans and the Obamacare plans and the Medicaid expansion that got the numbers to the lowest they've been in history. But we are seeing a slight uptick. As I mentioned here, they're running around 11% depending on the report that you run. Kaiser's got this number a little bit more conservatively, Kaiser Family Foundation at 10%. But we're seeing, I'm seeing it here from the health insurance data set there at the link below from the SSA archive. The government says we're running around 11.3, mid 215. This is kind of a cool graph. This is from Kaiser Family. This shows you the uninsured rate by state. Illinois is there in the middle in the 9 to 11% range. Illinois also has a very, very large proportion of Medicaid. I believe it's in the teens for the overall Medicaid for the entire nation. High preponderance of Medicaid enrollment there. A lot of the state's budgets and a lot of the hospitals' profitability hinges upon how Medicaid and the expansion happens. Colorado there in the middle, is running a little less at 7 and 8%. We had a very, very aggressive. We were one of the first states to expand. Very, very aggressive campaign surrounding that with the state in terms of enrolling emergency department self-pay patients on discharge and grants and things. Pretty progressive there. But you can kind of see by state and by region how polarized things are. No surprise, states that did not expand Medicaid have very high rates of uninsured, and a lot of them are closely evaluating that decision. We recently saw Kentucky move last year, and some others are filing, and Florida filed a waiver as well. We got that renewed. This is a cool graph from the Commonwealth Fund. It kind of shows you where the health plans have migrated since 2003 to last year. Roughly Medicaid has grown from 5 to 9% due to the expansion and the changing of the criterion through the ACA. We've seen the uninsured rate, of course, correspondingly come down. There's that 10% I mentioned. We saw the individual plans pick up. The SCR or cost sharing reductions are still floating out there. Trump recently released something yesterday or this week actually that's talking through short-term plans to help bridge the gap. That will fundamentally impact whether folks enroll in the exchange plans. I think we've got a very low enrollment this year from statistics I've seen. So we might see that number dip back down to the 6 or 7% range. Your standard employer insurance has also been dwindling. That's a function of many things. I would say first and foremost is affordability of premium. And then secondarily, you're seeing patients vacate off of that either to the government-funded plans, Medicare primarily, and obviously Medicaid if they waived out of their insurance at their employer or were unemployed. Medicare, a lot of people are like, hey, watch out for the baby boomers, the silver tsunami, if you could call it. I would argue that we're there. We're seeing a flattening of Medicare enrollment. That used to be all the rage in the 2000s. We got to be prepared to treat this population, this aging population. I think we need to start positioning our hospitals to start treating the uninsured population regardless of their age and where we're at, and specifically how we're going to address payment for millennials, which we'll talk through here in a minute. As most folks know on this call, private insurance subsidizes government insurance. The average reimbursement rates from the private payers are 120 to 140% of Medicare allowable. This is an AHA report. Medicaid and Medicare pay for most things, but not everything, and are usually under the cost line. And so you need to have this commercial insurance subsidizing the care that you're getting from the government insurance to allow folks to remain, especially in the not-for-profit space, in the black. Related to those shortfalls, about $55 billion in 2012 was not covering the cost of care from Medicaid, Medicare, and other government, including things like the VA and other plans that are out there, SSDI and such. That number's slowly going away. We're starting to see Medicare come in line with payments, things like MACRA and MIPS and value-based care. We're starting to help bring that underpayment, if you will, down, which is encouraging, but it's not at the levels that it was 10 years ago. Given this cost containment imperative in a very soft hospital market, providers have had a challenging year. Patient admissions have been soft thanks to rising deductibles and medical costs. Reimbursements have waned, and private payers are pushing patients to less expensive, low acuity settings. So you're seeing Walgreens and CVS and Amazon and clinics and urgent cares and independent freestanding EDs and start to provide alternative places for patients to go, and ambulatory surgery centers and independent diagnostic testing facilities, and those are also just other ways that hospitals have been subsidizing their inpatient bleed by trying to have all ambulatory markets there. And you're seeing expenses go up, but admissions stay relatively flat and volumes stay relatively flat at hospitals per the AHA, and that's caused certainly a cost crunch, which we'll talk through here in just a minute. Medicaid cuts are on the table. This is from March, obviously, but they have not gone. The budget office is still running projections. It still is in most bills. The Alexander Lamar bill and other bills that are being presented all have either through a block grant or per capita funding or a sequestration model of some sort, have an $800 billion reduction to funds for Medicaid, to understand how that they're going to cut costs fundamentally to that program. This would be devastating for the states that have a high Medicaid population like the state of Illinois. We could see those changes as early as this year. 2017 obviously didn't happen as those bills failed in the House and the Senate. Some made it to the Senate, but we'll see and watch. You're seeing the tax reform bills and other bills start coming through that will fundamentally, from a tax base, start to do something called budget reconciliation with Medicaid. I think you'll continue to see that as a docket item or a line item on bills as they come out. Well, let's walk through everyone's favorite, denials. So I'm not in denials by denials. They are prevalent at all of the hospitals that I've been in and facilities. They are something that have been there since dirt, and they still seem to challenge most. I haven't seen many doing it right, so you're not alone. These are some numbers to share with you. About 3 to 5% of your revenue is lost or leaked through denials. 20% of your expenses are attributed to bird dogging or trying to resolve said denials. That's the bad news. The good news is about 2/3 of them are recoverable, and almost all of them, save 10%, are preventable. Those are numbers from the advisory board. And the cash recoveries in that area can be anywhere from $5 to $10 million, can be returned back to a hospital by moving that, percent of net patient revenue a point or two back. Having a 4% net patient revenue move to 3 could easily get you in the multi-million-dollar savings range if you can just get your head wrapped around the types of denials and put standard work in place to prevent them from happening on a go forward or get them paid on appeal on the back. Folks are approaching denials different, or denials are vary by type of patient and certainly by how they're measured. Change, one of the largest clearinghouses in the country, recently did a denials report. Those are the numbers you see in blue. They had eligibility as number 1 and auth as second. HBI, I'm a big HBI fan, Health Business Insights, also did a report of their members of that and said that auth and pre-cert were their number 1 issue. I think no one would argue that those certainly are the top 1 and 2 for most organizations. A third, of course, is MedNec. I've heard inpatient medical necessity be a very large loss of revenue and leakage, level of care, days that are authorized, those types of things. Some folks still are struggling with outpatient medical necessity, primarily in the Medicare space, even though that rule's been there for quite a while, but just getting that ABN issued in a valid manner and getting it documented. Also, the commercial pre-cert MedNec rules often change. They're a function of what's coded, not what's necessarily being ordered, and that's a cause of consternation for a hospital. Clinical denials are a function of that, and of course, timely filing, which, at my hospital, we really scratched our heads a lot. We knew what those deadlines were. We knew they were coming, but yet they still came because we couldn't get what we needed to get that file back into the queue to get it resubmitted. 75% of all healthcare denials are because a patient was not eligible. The patient would have been ineligible because their policy has been terminated or modified. This comes from PMMC. Registration in hospitals is extremely complex. I had 20 to 30 different registrars at 4 different sites registering. It was just enough herding the goats, let alone making sure that they were enabled and armed with the best data possible at the time to be able to make the right decisions. 80% of claims are rejected because of some sort of an eligibility problem. This comes from Dolby. Registrars navigate multiple conversations with patients either at scheduling, the front desk, bedside at the ED or inpatient, and errors can cause significant increases in denials and claims. They need to be regularly retrained per this quote, and patient registration remind workers to check eligibility each and every time, verify it, check it twice, cross your T's and dot your I's. We had a 30-day rule. We'd roll it for 30 and then recheck it just because there was so much change in the benefits and or eligibility roles as patients came in. They cause downstream debt. I don't think that's a shocker to anyone on this call, but a top priority in patient access is to secure correct reimbursement based off of what is happening at the front and gathering that information and verifying it real time while the patient's in front of you or on the phone. They account for the largest percentage of denials, as I mentioned. There are several touch points in revenue cycle. presenting lots of opportunities for error. Any attempt to control denials reactively or in an isolated manner will be inefficient. I think we do chase our tails quite a bit, as Relays pointed out here as well, with what we're trying to do with capturing that revenue from leakage. Well, why check it? I think most of you know, but it's table stakes these days. If you're not checking eligibility at every instance, you're risking doing that procedure for free. One of my mantras with hospitals that I speak with is you have a choice. You can check things or risk doing it for free. And it's a very simple choice. If you don't check it, it's just like going to Vegas and you're putting $10,000 to $15,000 of billable charges on an outpatient side in surgery, or hundreds of thousands of dollars on the inpatient side. So it's important to be verifying this stuff as efficiently with the resources that you have. It avoids rework. That claim spins. Patient gave you a card. It was as valuable as duct tape. When the claim went, it denied. You didn't get paid, and now you've got a self-pay bad debt risk patient on your hands that may or may not be qualifying for charity. Or they gave you a card that was from their wife's plan that they're not on, or their plan changed. All of those things involve retouching a claim. The latest HFMA number out there is $35. 35 is what it costs to reprocess a claim. That is way more than the average hourly rate of a registrar or a biller. And so just contemplate trying to automate that where you can. Patient experience. Patients hate bills. They don't like them. They're confusing. They're hard to understand. And they especially don't like them when they say they don't have insurance and they did, or they can't afford a bill and no one offered them charity. And so it's very important to have processes in place that hardwire that for your teams. With use of easy or more accurate data, your staff will operate with more confidence to collect more money up front. So these are all things that can go horribly wrong with denials as a result of a data entry error or a registrar doing it. I don't think anyone's doing this out of malice. We have lots of things to remember when we're registering patients and processing claims and getting them ready to get out the door. But any one of these things will spin a claim and spin it quickly or impact your payment. And they're all things that are often told or recorded, but if it's entered wrong, not verified, or it changed, they all can impact whether or not you're going to get paid. And these are hard denials. These ones are ones that are very, very, very difficult to get paid on appeal, and have, especially with tight timely filing guidelines with some of the commercial payers in the 60 to 120 day range. Different folks are approaching denials different ways. As you can see here, about a little over a third of the industry has some sort of homegrown or traditional kind of process in their workflow, to where they may have a denials task force, or they're running reports of their denials and spreadsheets and assigning teams to work them, educating the intake areas either in patient access or in radiology or in the surgery departments or in the cardiology departments as to how eligibility and pre-auth and medical necessity things are happening. And then on the inpatient side, working very closely with case management, utilization review, things like that. About a third are using a vendor of some sort to automate that process. I feel sorry for the 20%, the 1 in 5 that aren't actively monitoring. They're probably leaking a lot of revenue, but that's what they said. And then about 10% are planning on having a dedicated initiative next year. Accountability also varies. A third have a dedicated team within the revenue cycle. That is their profit loss, or they are tasked with making that number lower. Let's get denials down by $1 million next year, or let's make it 10% less, whatever that is. Strategies like Lean or Six Sigma are being put in place. Epic folks out there have work queues that are doing that. Folks are using denials management software, or they're automating prior auth through libraries, things like that. CBO, the billing office, about 1 in 4 are doing that. That's a highly inefficient way, because they know what they know. They see the data that came across through coding and billing, but they're going to have to reach out to those ancillary departments, and that's a very laborious workflow. Sending back to the departments a best practice. Make them accountable. Hey, imaging this denied. It was something your team had input to, or hey, surgery, you guys scheduled this patient, didn't check eligibility or didn't get an auth. What's your process for that? Work groups, as I mentioned, and then finally just other. But this is a report from Health Business Insights, HBI. All right, let's talk about leakage, the revenue kind. So the challenge continues in the market. Medicaid has changing rules They change quite a bit depending on the type of state legislature and what's happening in the federal rules that are there. They may become eligible after the day of service. They may have let their coverage lapse. They may have not been to the doctor in 2 or 3 years but had an emergency event, and that needs to be retroed. And then when it was retroed, it didn't apply to the other accounts. So it becomes very difficult to kind of do the whack-a-mole, I call it, on Medicaid to make sure that that coverage is identified and passed to the other accounts. Commercial and Medicare eligibility also have holes. They've been dependent on the patient notifying them of the coverage that's there. If the patient gave the wrong card, an old card, or a card that wasn't applicable to the services getting, Medicare Part B only, for example, or Part A only, sorry, that doesn't have ambulatory benefits on it. Those types of things are all very difficult to navigate from a registration standpoint. The plans and payers are growing. If it has a blue suitcase with a plus and a minus on it and the words PRO, that means that you have to, start with an X on this registration. And if it's a yellow suitcase with, an H, then you have to put a Y in there. Those are very hard things for registrars to understand. I wish insurance cards were like the restaurant. You swipe it and it goes, right? It's like a credit card. You have to translate through a human what that policy number looks like to a plan ID, and that's a huge issue for a lot of hospitals in matching that mnemonic. And running rolls and verifying other coverage that's out there is a way to help prevent that leakage, which I'll get to in a minute. Multiple insurance is quite prevalent now. I think health care became expensive, so folks are covering their bases by having dual insurance. At lack of data flowing between payers and that subrogation workflow can cause issues for that. Retrospective look-backs for third-party liability, if it's an MVA or workers' comp claim, also can cause issue with payment and lagging AR. Medicaid secondary is often thought to be no value, but hey, I'll take the 10 cents if I can get it on what's remaining. That's better than no cents. And so it's important to run sweeps there as well. The cost report's becoming ever challenging. Medicare patients must be treated like all other patients. Locating Medicaid behind Medicare is a key to securing those write-offs. DISH payments recently got reduced, and the DISH thresholds have also became very hard to attain, and the rules are becoming more and more stringent. And so it's very, very important to identify those, and if you're a DISH hospital, to have those documentations and sweeps in place to make sure that you're getting your disproportionate share benefit as things come, even if the patient had commercial, but they may have had Medicaid secondary. These are all areas where health systems and hospitals tend to have sprung leaks over the past few years. And they're things that you're usually not looking for. They're not as simple as the eligibility, authorization, medical necessity sweep. Finding the correct insurer, I mentioned. Timing delays between eligibility windows. They may have had coverage, and then a soft denial came through that wasn't really reflective, but someone took that to heart and never went back and checked again. Correct payer for certain types of service, like I said, shadow bills. Uniquely Medicare billing challenges, having the right modifiers and things on those bills that denied once, but if you submitted it another way with the right documentation and the right modifier, it would pay. Information gaps with no meaningful activity. Clinicals maybe weren't there. Atypical billing regulations, the ZPICs, the MACs, the RACs, those types of guys. Zero balance accounts, just because the account's zero doesn't mean you got paid right. And so those are ones that are good to go look at. Bad debt accounts for deductibles and copays, no activities, but may or may not have a secondary payer that could be picking up that patient benefit. Outpatient primary payers when multiple coverage exists, and finally billing setup. Maybe the contracts aren't mapped properly, and you've got underpayments and overpayments happening, and those are there. But these are all revenue that's just leaking out the door. This is kind of a top 10 list that we had put together here at TransUnion to help you identify areas to go look at, and we've got some tools and solutions too that can help with meeting some of those needs if need be. Good segue, solutions and tools. Now that I've terrified you about all the leaking revenue, let's talk about ways that I've seen in the industry that folks are addressing it and trying to fix it. So both these surveys were performed recently. The top one in the upper left corner is from HBI. That's Health Business Insights, and they asked about 350 CFOs at the organizations, what is a top revenue cycle priority for you? The bottom right corner is one from HFMA, and they said which revenue cycle management capabilities are in your organization, or your organization going to focus on most next year. There is some congruence between these two lists. 7 out of the 10 things, if you look closely, are on both. denials, CDI, productivity, coding, analytics. Those are all things that most organizations are working on next year. I worked at an organization for quite a long time. I knew I couldn't bang out a list of 12 things in 1 year. I'd tell our leadership and my team that worked with me, which 3 can we get? Let's work on the next 3 next year, and hopefully those next 3 are the same 3. That's how we did it. One thing that's of note is about 80% of these, the majority are enabled by technology of some sort. Performing denials or point-of-service collections or improving the patient financial experience is extremely challenging to do without leveraging some sort of automation or technology. Here's Mr. Wiik's 5 ways to keep your revenue cycle on course. Think of it as a compass, if you will. But number 1's kind of an obvious one, but establish funding mechanisms, but the key is in advance. Folks that are out there that have an electively scheduled report of all the patients that are coming in tomorrow or the next month or next year and aren't looking at it, actively scrubbing it, and doing patient financial clearance on it are not following best practices in the industry and are putting a significant amount of revenue at risk and leakage because they're not scrubbing those accounts. And I've heard the arguments about we don't have the resources, we can't do it, it's a lot of work. But you have a choice. You can do the work or follow up on it later. It's pay me now or pay me later, like we talked about at the beginning. It's important to scrub those accounts and make sure that those patients have a funding mechanism before they come in. Sometimes that funding mechanism may be charity. Sometimes that funding mechanism is, hey, how are you going to pay for this before you come in? Otherwise, we don't want to send bankruptcy notices, or the collection agencies don't want to do that. So it's important to kind of have those discussions and get a financially engaged patient up front. To that point, educating patients about cost and coverage, benefits literacy is a huge issue in our country. Most patients do not understand their bills, do not understand why healthcare costs too much, and also don't really understand why they have to pay for it. And those are all things that the hospital, unfortunately, has been placed in the unfortunate position of having to navigate on behalf of the patient. So we used to call it the art of the ask at my hospital. It's important to at least have the conversation, talk through it, and have tools that enable that conversation to happen. We've checked your insurance, Mr. Wiik. I got good news and bad news. It's covered. The bad news is you owe me some money. Would you like to pay for that today? But at least the patient knows. If they don't have insurance, hey, I noticed you don't have insurance. What's your financial plan? Can the hospital help you in that plan? If they can't help, then you have discussions about whether this is the best course of treatment with the physician. I know that gets dicey, but at least those conversations are happening about the cost and coverage. It's the only industry, gang, where patients navigate it and have very little interaction about the cost of things when they're buying groceries, going to rent an apartment, a house, a stereo, the car mechanic. There are all conversations that happen concurrently and proactively about cost. And I'm very, very concerned and somewhat confused at why our industry struggles with this, because it's not that hard of a conversation. And I'm starting to see some very innovative things with some health systems where they're guaranteeing that amount that they're talking about, and you know what? It's what's best for the patients. They're figuring it out. Collections are important. It's much cheaper to collect today than tomorrow. I used to tell that to my team. The cost to collect becomes much more expensive tomorrow. So enabling estimates up front and establishing those funding mechanisms and getting a first payment enhances behavior as well as lowers collection costs. Actively segment those accounts that you missed on the back into high yield accounts. What that means is, as you have patients that have a balance either because they're uninsured or have a high deductible, what is their likelihood of payment? What's that look like? What's the stratification portfolio look like? Is this a patient who pays their bills? This is a patient who can't pay and really needs charity. You're really differentiating between their ability and willingness to pay a bill. And then finally, having a back-end sweep with coverage discovery or something that's cleaning up those uncompensated care. There's going to be accounts that just get missed, gang. Our studies have shown at TransUnion that number is anywhere between 1% and 5%. Doesn't sound like a lot, but 1 to 5% of your revenue is. And those are accounts that just got missed. The misspelling of a name, Martina Galindez Spencer or John Smith, and just bad things happened quickly and coverage wasn't identified. Or, it was a patient that came through the ED at 3 in the morning. No one saw him from the registration side. It was incomplete reg, and they showed up as self-pay, but where they fact had, Anthem coverage, but no one checked. And so those are all just kind of like a safety net to have on the back to help clean the team's work up front and also just bring cash to the door to finding coverage that was there and helping you get entitled to that protected revenue that you have. So eligibility, let's talk about that for a minute. I hear this a lot. I'm verifying eligibility, but I still have a ton of denials. What the heck's my team doing? What are they doing? Why is this getting screwed up? So I thought I'd put a slide together for you guys on this. So to ensure the value of an eligibility check that you're running, and I'm sure most of you are, 3 things have to happen. The timing and communication of the check. So if you have eligibility and you're running it, when are you running it? Did you run it today for tomorrow? Did you run it last week for next week? Did you run it a month ago and haven't ran it again? And are you running it on every single account? Your inpatient self-pays, for example, that's one that's typically missed. Some of your emergency department patients, perhaps an ancillary clinic schedules things, maybe an anti-coag clinic. There's always accounts that seem to get missed in an eligibility check, right? Either from a timing or a frequency standpoint. So in shorter terms, run the dang thing and run it a lot because it's important to verify that. Every other industry does that with your credit card and wants to check to make sure there's payment on there before you leave the restaurant or the mechanic, right? Or the grocery store or the retail store. Second one's very important. Hardwired review and screening of the response. So you ran it, did you look at it? And if you looked at it, did you change behavior? I think of all the things I see, this is why eligibility checks fail, is you're running and you're spending and investing the time and resources to get it wired into your EMR, wired into your workflow. You're spending money either with TransUnion or another vendor and getting the responses back, which are very, very good, but you're not acting upon them. Or you didn't act upon them later, or you didn't recheck again later and maximize the value of that. And so oftentimes, you'll get patient not covered for procedure. Well, does the registrar know what to do with that? Do they switch it to self-pay, and then it follows the self-pay workflow? Or do they see it and go, that's interesting, the next guy down the line will get it? It's very important to have a hardwired workflow with your eligibility response to ping it into a queue that has worked before that date of service, ideally 72 hours before that date of service, because once the patient's here, it's real hard to kind of turn that car around on the track, and I would argue most of you don't, and nor should you. The patient's there. It's not their fault you didn't figure out what was going on before they got there. You knew they were coming. And in the emergency room, you know they're going to leave. And so you have an opportunity to talk to them before they go home. Same with your inpatients. And then finally having this in policy procedures for understanding like what happens. So, it's very simple. If eligibility check doesn't run tomorrow or run tonight or make phone calls or switch over to a portal, whatever that fail-safe workflow. If the carrier didn't have their ears on and they weren't talking at the time, what is the workflow? If it ran and gave you a response that the procedure is not covered, what's the workflow? If they ran you a response that says it's covered if it meets the following criteria, what's the workflow? All of those things have to kind of be defined. And really, I'd say there's less than a half a dozen of them. There's not that many, and I've got them in a list somewhere if you guys want them. But it's important to have, when X happens, do Y. Because the response is only good as the action you take upon it. Otherwise, you wasted your money on it, right? And I know most of you are running eligibility checks, but I bet some of you aren't doing these 3 things 100% of the time. I hope that was helpful. Here's an example workflow. Run the report, submit it to a clearinghouse. Clearinghouse will check. Clearinghouse will come back and tell you. Those benefits are documented. This is different than an eligibility check per se. It's basically taking a batch report, sending it out, and financially scrubbing it before the patients come in, an industry best practice. You certainly could do this in real time or at scheduling if it doesn't come up your call queues, but another way of doing it is get time and dates assigned. That's scheduling's primary role, and then have financial clearance happen as a secondary step, and then work the exceptions, right? Accounts that lack coverage or are high risk are flagged, as I mentioned. This patient's insurance came back as ineligible, or more information required, or CAN ID, whatever those ANSI codes are that came through. Or they're self-pay, right? They came back and didn't find anything. Outbound contact to the patient and the care team for alternative funding, financial counseling, insurance verification, utilization review. Sometimes it's the referring physician, who knows, the patient themselves, those types of things. But what I see a lot of gaps are these last 2 steps, flagging the accounts and then acting upon them. So hopefully that's a workflow that you guys can take and put in place. Hospitals have 3 areas of focus to contain costs in 2018. Clinical variation reduction. I'm having patients come through with diagnoses following evidence-based practices. Why did this one cost more than that one? How come this one stayed 3 days longer than that one? Why did this one get an infection and that one didn't? Those types of things. But I know that's on everyone's radar. It may not be a function of revenue cycle, but I had case management reporting to me, and we looked at it very closely. Labor, everyone's got a budget. Everyone's budget's lower next year for the most part. And so, how are you managing costs because you're not getting incremental revenue? I was talking to a CFO the other day whose payer came back with an increase for next year out of the gate at like 1.5%. That's less than inflation, gang. So, something has to change. And so managing labor is certainly number 2. And then 3, everyone's favorite, revenue cycle management. I was impressed that number 3 made the list, but I love the quote that came out of this article from Healthcare Dive. Costs have remained flat in recent years despite consolidation that's happening in the industry, indicating that there's savings out there that's unrealized by optimizing functions either through automation or using things. But technology will be a critical tool for cost containment efforts, ideally in collaboration with the EMR and analytics to help target savings. So I thought that was interesting. Hospitals that that apply presumptive charity scoring and back end typically see a lift in the neighborhood of 10 to 30%, gang. That's not 1 to 3%. That's 10 to 30%. So there are accounts that are marinating in the back end of your revenue cycle that can have a 10 to 30% lift, either from moving them from a bad debt or charity case into a payment case or moving them from bad debt to charity. I know that doesn't necessarily get you a lift in revenue, but it does get you a lift on your Form 990 and your Schedule H and your not-for-profit position if you're a not-for-profit. So it's just something to think about. Stratifying that bad debt portfolio is imperative these days. You want to make sure you have the right patient. They're not committing fraud. We're seeing a lot of that. Fraud surpassed the $1 billion mark this year. It's up about 26%. It's moving up quite a bit. I don't know if any of you have a returned mail problem, but it's important to look at that as well and understand where you're at with those functionalities and whether you're going to send statements to patients that are wrong or have the wrong phone number, things like that. Insurance discovery and presumptive charity is important to run that as often and as early as you can. As I mentioned before, finding a coverage mechanism in advance of care is ideal, and if you missed it, at least buttoning it up at the end. But balancing that bad debt portfolio into those payment buckets, reclassing those accounts as charity, and then finally, what kind of patient do you have in front of you? Are they going to be ones that can pay you over time, ones that can't pay you at all, or ones that don't want to pay you and make decisions so you can help put those ones that are truly in need into those buckets that you need? We're seeing an evolution, guys, in transformation in revenue cycle right now. I think it's been exciting to watch. I've been in the industry about 20 years, and I'm seeing a lot of traction now. And folks really are moving away from this traditional revenue cycle. It's funny, I heard a CFO tell me, healthcare service shoplifting. It's the only industry, he was a CFO, he's banging his hands on the table, and he says, you know what this is? It's shoplifting. Patients come in, they get what they want, and then they never pay us, and they stole from us. Interesting perspective, but nonetheless, I see the spirit of his point in that he was saying that without having engaged patients and having conversations, patients really expect some of this stuff to maybe be picked up somewhere else, or maybe the hospital will forget about it. Statements on a 90 to 120-day pay cycle, that's an eternity, but most self-pay patients, that's about the time they take to pay you. Downstream billing, bad debt risk, so not having a conversation results in rolling the dice downstream. Payments by mail, if any of you are still sending statements in the mail, know that the yield on those statements in the mail is significantly less than mobile statements. And I'm not saying that you need to purchase mobile statements, I'm just saying that your yield is significantly less. Most patients do not pay their bills by mail. They maybe get their water and utility bill that way, but everything else is auto withdrawal, or they've got it set up on some sort of PC or phone or something. But if you're still sending a statement out hoping you're going to get paid that way, I'd be very interested to hear the percent yield that you're getting on that mechanism, because it's an old way. And then inquiry payments, where, hey, how much can you afford today? That's not a good question. It's, hey, it's this amount. How much will you be paying? Trying to figure that out. So we're seeing a transition from traditional to innovative, to where patients are being financially cleared. I'm seeing hospitals educate the employers. They'll sit at the Chamber of Commerce and sit down and meet with the top employers and go, what are the health plans in this county? Are they Kaiser? Are they Blue Cross Blue Shield? Are they Aetna? Are they Cigna? Are they Humana? What do the benefit plans look like? Let's run some numbers. Let's see what a knee surgery would cost, an ER visit for a level 3 visit, a primary care physician visit, just so the employers and the hospital and their employees are all on the same page. They're kind of these open forums in a library to where all 3 parties are at the party talking through it. Pre-service estimates, I've kicked that horse. Propensity to pay, leveraging credit or alternative data, a lot of traction right now. with alternative data. I think most of the market's still pretty spooked with credit and healthcare, lots of rules and things with that. I do see hospitals using it primarily on the back end to help stratify that bad debt portfolio to understand the type of patient that they have. Haven't seen a lot of prevalence on the front, although that's an industry best practice to do it. Anything else that's at that level of expense is financed. Payment plans, seeing a lot of work with this. It's not necessarily about point of service collections anymore. It's about establishing a payment plan over time, because the amount, frankly, you can't say, hey, Mr. Wiik, it's $4,500. How are you going to pay today? I'd laugh. I'd be like, I'm not paying you that today. I could pay you that, over the next 3 months or 5 months or a year. What can you do for me? Loans are starting to pick up traction as well. I've talked through point of service collections. A lot of single billing offices and consolidated bills. You're seeing that. Bundle payments has kind of been bouncing up and down with Medicare, but you're seeing that happen. Guarantor balance, a lot of traction there as well. I'm seeing hospitals kind of run that report and kind of have a portfolio, either through Epic MyChart or other things to say, hey, the Wiik family expenses this year so far is at $895, and that's a function of these 3 accounts, and would you like to pay for all of those today? And how will you pay for all of those today? And can we set up a credit card that attaches to those so when people come in, it just hits that card and it's auto withdrawal? Very, very innovative stuff there. Retail transparency, consumerism, you guys have all heard about that, but it's happening. I think the millennials are going to, certainly my book talks about that as well, is going to, amplify the need to interact with patients differently through portals, mobile phones. You're going to have to open up the Komodo a little bit more at hospitals, I think, and they're going to really want to know more about how your contracts are structured and what the out-of-pocket represents to them, and there's creative ways of doing that. And then finally, bad debt segmentation, which I talked about. So cleaning up your uncompensated care is another workflow for you. You can run a weekly batch, look for insurance, see if you find it. This is on the back. If you can't find it, then run all those accounts through charity. Make sure and bring an FPL back, so maybe they qualify for your own hospital's charity program or qualify for Medicaid but never enrolled. Maybe they don't qualify for anything and need a 50% down payment. You can stratify them out. Then you could use propensity to pay for those that get stratified out. This patient should pay 50% of their bill. This patient should pay all their bill. This patient should pay 10% of their bill for the next 12 months. Those types of things. Really getting at that ability and likelihood. And then finally, determine which ones qualify presumptively for FAP, and then save some money on your collections costs. It doesn't make sense to send a statement to a patient 3 times that can't pay it. And so kind of stopping that cycle. And it also doesn't make sense to send millions of dollars or billions of dollars to an early out or a collection agency when your team, if you had one, could have collected it at a much lower cost. Unified self-pay, increase those reimbursements by identifying commercial, Medicare, and Medicaid. Improve your cash flow, as I mentioned. Reduces bad debt. Finally, your vendor contingency fees are something you could save. I'm seeing hospitals kind of on the fence with this. A lot are sending their stuff out day one and paying the 14 to 25 points to those early outs and third-party collections. I'm seeing other hospitals take it back. Like, you know what, I'm not paying 20% on the dollar on this stuff anymore. I'm going to try to collect it myself, or I'm only going to give them the scraps. I'm going to keep the high-yield accounts, pre-score them, and then ship the other ones over the fence. And then 501R, everyone's favorite. Lots of action with that. I have a whole deck on 501R if you want to see it. I presented on that last week to another chapter in Pennsylvania or New Jersey. Lots of IRS activity happening with 501R. They've got a team. They're citing folks. A large percentage of hospitals are having findings. And so a lot of folks think they have this under control, and the IRS has said, no, you haven't, and they're acting a lot like the RACs did, and infringing upon getting penalties and other things in place as they come. Revenue assurance, locating underpayments, reporting on that coverage, and driving incremental revenue, and having a safety net for revenue leakage is also a best practice. Closely monitoring the relationship with the provider, the payer, and the patient, how they're paying you, when they're paying you, whether they paid you correctly or not. Examples of that are like third-party liability, transfer DRG, patient bad debt. There's all solutions and workflows out there to plug each one of those leaks. Ensure efficient and timely reporting on payable coverage and claims, so finding the coverage that wasn't there, and did that payer pay, and backstopping, I call it, your timely filing requirements to make sure those claims go over the wall before that happens. Multiple delivery mechanisms based off workflow, So are you checking front, middle, and back? How are those reports coming? Are they integrated with your EMR or not? Are the batches sorted? Or are you still working your cradle to grave alpha split workflow? Demographic discrepancies in real time is an industry best practice. Understanding that the plan is matched, the patient's matched to the plan, and the patient's demographics are matched to them are all very key tenets of making sure your revenue is not leakage. And make sure you're looking at all of this holistically, identifying the valuable and unknown coverage and payments that's out there, because again, about 1 to 5% of your revenues get leaked out the door that can be prevented by putting workflows and tools in place. Think of it as checklists and gates, gang. These are the big four. This is the blocking and tackling. You got to get these four right in your revenue cycle, or revenue is going to leak all the time. Eligibility. Does the patient have something? Are they covered? If they're not covered and they're self-pay, what's the process? Pay up front? Screen up front? Both? What if they say no? What are your policies and procedures? Are you running that yourself? Are you using Navinet or payer portals or other folks? Are you using TransUnion eligibility or other eligibility? What are you doing? And is that integrated? What's it look like? And is it hardwired like I talked about with those behavioral actions on the response? Then you're verifying it. Does it cover what the patient's getting? Is it in or out of network? Is it meeting authorization and MedNec requirements? But they may have coverage, but that coverage may not cover the thing they're getting that day. What's the patient owe? Are you using a matrix that's duct taped to the monitor, or do you have software doing this for you? Is it part of Epic? Have you enabled it fully? Is it based off contracts? How accurate is it? What's your collections rate? What's bleeding back out the door? Do you need payment plans in there as well to help navigate that collection? Are you putting folks in FPL tiers? And then finally, what's the collection? Was there coverage out there you didn't know about? Was there payments out there that you didn't get paid right on? Was the payment coming in at the time that it was supposed to, or could it have came faster? And then most importantly, I kind of hammer this a lot, but do you have stops and gates for each of these? Because you really should go back to the start if you screwed any of this up or your team missed it, so that you can stop and escalate it, or otherwise you did it for free. So I'll finish here on revenue assurance, and then we'll open it up for questions, but protect your revenue from leakage. Get someone else to pay for it. Find that coverage, Medicaid, secondary coverage, something else, charity program, as weird as that sounds, that's still, if the patient really qualifies, that is someone else technically funding it, be it your foundation or someone else. It's not great money, but it's there. Streamline patient payments. It is extremely difficult to pay a hospital these days, but work on that. Maximize reimbursement for each instance of care on your transfers, on your multiple coverages, on different procedures and different eligibility responses. Are you getting paid the way that you should have gotten paid? Third-party liability, those types of things. Constantly look at your denials and rejections and underpayments and make sure you're maximizing those, and then leverage technology with anything that you can to help automate it and empower your team. I've got 6 minutes left. Went a little longer than I would have liked, but it's chock full of good stuff there and there. So, Nikki, I'll open it up for questions if folks got it.
Awesome, Jonathan. You never disappoint. Great information. And before we jump into the Q&A, just reminding everyone, simply type your questions into the questions panel located to the right of your screen, and we'll take as many as time will allow. One question that I will address is about accessing the slides. So if you missed it, on the right, you'll see a handout section. Just expand that, and you'll see the PDF icon where you can get access right now. All right, so let's tackle this first question. So obviously TransUnion works with many clients that are faced with the challenges that you discussed today. Is there any one program, process, or strategy that you've seen be really impactful?
Yeah, I think the coverage discovery stuff is pretty simple. It's kind of a no-brainer, I call it. There's just stuff that gets missed as patient access and registrations trying to do the best they can. It's a high volume, high detail, high error area, and it's very easy to misspell a patient or transpose coverage, or it's also conversely very easy for a patient to misrepresent the coverage that they may or may not have. And so we're seeing with a lot of our customers lots of traction in that area, because it's just things that get missed that no one thought about, that they just assumed was bad debt. And in fact, finding that coverage and then rebilling it, it just brings cash, and it's simple. I think that's the biggest strategy I've seen from a discovery standpoint. I'm seeing a lot of traction too in estimation in terms of hospitals really trying to create what I call a patient financial experience, kind of that nirvana. They're trying to engage that patient, provide an estimate, talk finances with them when they can, figure out what that payment plan is going to look like, just like you do with any other transaction as a consumer. Hospitals are starting to get on that train and figure that out. But those are two big ones.
Awesome. Thank you for that. The next question is, could you speak to how accurately you think hospitals are measuring denials? Are they using any type of standardized reports?
Yeah, I think it's going to depend. You know, a lot of distinctions are, I think there's kind of three tiers, right? Hard and soft. They're kind of like eggs. but you know, a hard denial, I had a definition in this deck that you saw. Those are ones that, you know, you're not going to get paid unless you take some sort of action of finding the correct information and getting it resolved, or there wasn't coverage in the first place and you're kind of stuck. And unless there's some alternative. And then the soft ones are, well, this needs clinicals, or there's an off laying around somewhere and you didn't put it on there, or the procedure changed and you need to have dictation that supports why it changed. I think those all impact, quote, accuracy. You know, most folks record denials as a percent of net revenue. Industry benchmarks from HFMA hold that number at right around 1 to 2%. It was at 3 a few years ago, but it's slowly coming down because I think folks are getting better. That's industry best practice, by the way. The average is running closer to 3 to 4% of your net patient revenue. From an accuracy standpoint, I guarantee none of you are accurate in looking at your denials, but you know very well what you wrote off last year, but not why and how many and whether it should have happened or not. And that's the key, is kind of tackling that from a priority standpoint. Where am I leaking the most dollars? What are some quick things that I could take away and apply now? Can I get a library in place, for example, that will just tell me whether or not it's required or not? That's a simple first step. And then if another good secondary step is, if the procedure changed, is there an alert that can tell me that? You all are on order entry systems, and when an order is edited, you can know that, and then that would be something that financial counseling or insurance verification could look at and update that authorization in real time before that claim drops during the coding claim hold, right? So those are things that I think impact the, quote, accuracy of whether or not that denial is being reported.
Thank you for that. And in terms of drivers, are there specific drivers that you're seeing to this uncompensated care?
Yeah, I think it's the usual suspects. You know, I think you're seeing high costs. So as costs go up, so does uncompensated care as a function of that. You know, that's the affordability quotient, and also just as there's more dollars that are out there that need to be covered, and hospitals have an increasing burden. They're kind of the last in line, right, from everything else. You go to the ER when everything else fails. Well, that's a very expensive place to get care. It may not be the right level. It's the right for most things, but not all things, and that can cause a large amount of bad debt to happen. I think costs are one. I think number two is there's just a lot of disruption right now. A lot of patients kind of defected from the Obamacare plans and have decided to roll the dice and become self-pay patients. I think you're seeing underpayments from Medicaid and Medicare become more prevalent as payer mixes dilute. And so you're starting to see hospitals report that they didn't get the money that they were entitled to from those government plans as well. And so you're seeing that. Those are the top probably 2 or 3 that occur.
All right, thank you for that. So we have approached the top of the hour, and I just want to take a moment to thank our members and the healthcare community for joining the call. In fact, I hope you can join us for our next installment, which will take place on March 28th. And the title of that webinar is Top 7 Methods to Improve the Financials of Your Physician Enterprise. As you exit, you will be prompted with a survey. We would appreciate you sharing your feedback about today's event, as well as some other topics that you're interested in hearing in future webinars. So thank you again, Jonathan Wiik of TRANSUNION. As always, it is a delight to work with you on these engagements. So thank you, Jonathan, for
Thank
sharing
you,
that.
guys.
Absolutely. And on behalf of HFMA First Illinois, thank you again for joining. Have a great afternoon, everyone.
Bye-bye.